Hi, well, good afternoon, everyone, and thank you for joining us for the Medical Board of California Midwifery Advisory Council meeting. This meeting is being conducted via WebEx. Public comments will be heard for each agenda item for individuals wishing to speak. In order to be ready for public comment, we ask you please ensure that your comments can be heard clearly by being connected to the audio of this meeting through the proper method. If you're having difficulty hearing the audio of this meeting, it could be because your device you're connecting with has bandwidth limitations. If you do have difficulty hearing the audio of this meeting using your device, please click the ellipsis button at the bottom of the WebEx application or the audio and video menu item at the top of the WebEx application, and then select Switch Audio. You will see an option to call in and will be provided with a telephone number, access code, and attendee ID that can be used to connect to the meeting audio via phone. Using the information provided, it will automatically disconnect your device's audio and connect your phone to the name you joined the meeting with. By using this method, if you're having audio problems with your device, this will allow you to still participate and hear the audio of the board meeting. Please see the instructions on how to connect link on the last page of the meeting agenda for step-by-step WebEx instructions, including screenshots. Thank you, Ms. Weisner. You can now start the meeting.
Hello, everyone. Once again, my name is Madeline Weisner, and I am the chair of this advisory council. I would like to welcome you to the MAC meeting. Welcome back. Since this meeting is being conducted via WebEx, I will ask that all MAC members and speakers to announce themselves by name before speaking for clarity of the official record. All MAC members are able to unmute themselves to speak during the meeting. Please place yourself back on mute when not speaking to reduce background noise for all participants. Following such online meeting etiquette will ensure the best audio quality for everyone. During each call for comments from MAC members and speakers, we will ensure that all comments that can be accommodated are heard before proceeding with the agenda. During each agenda item, the host moderating this event will activate the Q&A and hand-raising features of WebEx and will ask anyone wishing to make a public comment to indicate so by replying yes in the Q&A window or by using the hand-raising features. The host will then call on individuals who indicated they wish to make public comments by name. When called upon, the host will unmute the microphone of the individual, and they will be able to make their public comment. After the comment, the individual will be placed back on mute. Please see the agenda for WebEx instructions on how to connect from the link on the agenda and additional instructions. The board's IT staff will continue to assist me with receiving the public comments. MAC members, as a reminder, during today's meeting, any items requiring a vote will be done by roll call vote. This means that once a motion is made and seconded, Ms. Moriarty will call each of the names individually to request our vote. I would now like to call the meeting to order and ask that Ms. Moriarty please call the roll.
Thank you. Faith Freeman.
Here.
Thank you. Dr. Kenneth James. Tamara Robertson.
Here.
Thank you. Mason Wilson Tenev.
I'm here.
Thank you. And Madeline Weisner.
Here.
Thank you. We have a quorum.
Awesome. A quorum is present. We did it. Moving to agenda item number 2, which is for public comments on items not on the agenda. Are there any public comments?
Anyone would like to make a public comment for agenda item number 2 here, please go ahead and use that hand-raising feature or type anything into that Q&A window. Give it a few seconds here to see if anyone queues up. First up here, we have Rosanna Davis. Rosanna, let me go ahead and send you that request. Should be receiving a prompt on your end to unmute. Afternoon, Rosanna, are you there? Looks like your line unmuted if you're on.
There we go. Is that it?
Yeah, we can hear you now. Please go ahead.
Good afternoon. I'm Rosanna Davis, President of California Association of Licensed Midwives. Appreciate the opportunity to update everyone on a couple of midwifery related matters. The first of which is that Quorum and our sister organization CAM, in partnership with Cerro Coso Community College in Bakersfield, won a $500,000 grant from HCI to start a licensed midwife AS degree program. The program will meet the criteria for both medical board approval and MEEC accreditation, and the timeline for the program to begin is fall semester 2026. There will be opportunity for an advisory committee to hear about the plans and to weigh in at multiple junctures. If anyone here, whether you're a midwife, an educator, or a member of the public related to midwifery, and you would like to be part of such an advisory committee, please contact me at president@calmidwives.org. Also, CALM this year is co-sponsor for AB 55 BONTA, the Freedom to Birth Act. The intent of the bill is to remove arbitrary and capricious criteria for birth center licensure in California. The bill will be heard next in Assembly Health Committee. Lastly, CALM recently commissioned researchers Melissa Cheney and Marie Bovia to review the California LMAR and make recommendations for potential changes so that the data could be used for quality improvement and/or research. Their conclusion was that it was not usable for quality improvement and/or research, which understandably was not its original intent. But we're looking into ways to get better research and data on licensed midwife care in California. You can see the brief. I'll upload it later today. I haven't gotten to it, but it will be at calmidwives.org/LMAR. Given that, again, the original intent of the LMAR was not for QI and research, as well as the potential for resources involved to overhaul or make changes to the LMAR, CALM is not pursuing or recommending changes to the current data collection at this time. Instead, we're working with various stakeholders to explore the feasibility of contributing to the Community Birth Data Registry, a community midwifery data collection system that was established in Washington State under the auspices of Foundation for Healthcare and Quality. That concludes my remarks. Thank you.
Thank you for your public comment. At this time, I do not see any additional requests.
Awesome, thank you. Moving now to agenda item number 3, which is approval of the minutes from the September 12th, 2024 Midwifery Advisory Council meeting. Are there any additions or corrections to the September MAC meeting minutes from the members?
No.
Hey. May I have a motion to approve the minutes from the September MAC meeting as submitted?
Motion to approve.
Does anyone second?
Second.
Yay. Is there any public comment?
Anyone like to make a public comment for agenda item 3? You can use the hand raising feature. Type anything in that Q&A window, get you called upon. A few seconds to see if anyone raises a hand. Not seeing any requests, Ms. Weisner.
All right, Ms. Moriarty, could you please perform the roll call vote?
Yes, Faith Freeman.
Yes.
Thank you. Tamara Robertson.
Approve.
Thank you. Mason Wilson Tanev.
Approve.
Thank you. And Madeline Weisner.
Yes.
Thank you.
All right, the September 2024 MAC meeting minutes are approved. We're doing great. Moving on to agenda item number 4, which is the update from the MAC chair. I wanted to take a moment to update you on some developments that have taken place since our last meeting in September. First off, before I forget, because I did last time, I wanted to remind everyone that the Medical Board's enforcement program has consultant and expert reviewer opportunities for licensed midwives. Consultants evaluate the specific standard of care issues raised by a complainant to determine if further investigation is required. Whereas expert reviewers provide expert reviews and opinions on board cases and testify at administrative hearings. For application and eligibility requirements, you can go to the board's website at www.mbc.ca.gov. Click on the enforcement link and then the links to the medical consultant and expert reviewer programs. I did it. So next, I want to just take a moment to acknowledge the midwives and the families who are continuing to experience devastation from the latest wildfires in Southern California. Wildfires this year alone have burned over 50,000 acres. And as in every crisis, licensed midwives continue to pool their very limited resources to make sure maternity care in the state is uninterrupted. Midwives work to reduce the harm being caused to childbearing families by these fires. Some midwives I spoke with even continued caring for their clients through their own evacuations. One birth center in the area continued to operate without electricity. Midwives from regions outside the fires absorbed a lot of displaced families as well and worked throughout the state to make sure their clients had high quality respirators and HEPA filters. And this is not the first time that we've seen this happen. In times of crisis, midwives continue to take care of people. And we also know that these fires pose really significant and lasting risks for families, for newborns, for pregnant women, and for the midwives themselves. And we're going to keep seeing the impacts from this and from climate change for a very long time. Over the last several months, midwives have expressed to me that they don't have the protections that they need or the resources that they require when they have to provide this care in such hazardous environments. And we saw, we've seen this since the beginning of the pandemic as well, for sure, for everybody. From a policy standpoint, we know that we can appreciate that DCA has provided postponements on renewal fees for survivors of the fires. But our current regulation does not really account for the growing reality of midwifery care in these disaster situations or states of emergency that seem to be increasingly common for us. Midwives in these states of emergency service first responders as emergency responders, as well as the guardians of normal physiologic birth in what are often very abnormal circumstances. All this being said, once we're at agenda item number 13, I will be proposing a future agenda item in specific regard to environmental exposures we know midwifery clients and midwives are being forced to endure with these fires, and I'll chat more about it then. But speaking of ongoing crises, it's very clear to me and to most of the midwives I speak with that the way licensed midwives in California are paid is largely untenable. The current rates offered by private insurers aren't enough for businesses to stay open. The rates needed to sustain a self-employed licensed midwife practice are far in excess of what most California families can afford and what most payers are paying. So I wanted to talk a little bit about the work that MACA has been doing. MACA is an organization called Midwifery Access California. It has finally released its final draft of its payment model for midwifery, which is the first payment model in California specifically designed for community midwifery care, and it is shaped around licensed midwife care. This payment structure was created specifically to address midwifery care for Medi-Cal beneficiaries, but I do encourage any of the midwives on this call to take a look at it, to bring it to the payers that you're working with, including clients who are utilizing private insurance, the health shares, as well as people using cash pay options. The goal of this model is to keep midwifery practices open and thriving, which they are not right now, as well as to normalize reimbursement rates that ensure the sustainability of midwifery services. Families and consumers can't have midwives if there are no midwives to help them. And we're quickly approaching that, you know. The model also considers the comprehensive care management and wraparound services baked into the midwifery model of care, which current insurance models don't capture. And I will say that it's much more in line with payment models utilized by countries where midwives make up the majority of primary care providers. So that being said, I'll also be bringing this up on agenda item 13 when we talk about topics for future meetings. In regard to education and workforce enhancement, the Department of Healthcare Access and Information, known as HCI, as Ms. Davis said, has recently awarded a total of actually $1 million to licensed midwife education programs, which is pretty freaking cool, right? One award of $500,000 is to the community college program that Ms. Davis spoke of. Some things to know about that: it's in Ridgecrest, California. And in this region, there are 11 midwives of any credential for every 10,000 births, just to give you an idea of the really critical shortage of midwives where this program is taking place. So that's pretty cool. Another award, also of $500,000, has been issued to Common Sense Childbirth School of Midwifery, which is an existing MEEC accredited midwifery school based in Florida that will be offering a California-based satellite program. This program is also set to start in the fall of 2026. So by the end of 2026, there will be 2 new midwifery schools in California, and this is incredible. These awards really represent a huge step forward in providing local midwifery education options and addressing the ongoing provider shortage in our state. As we know, many counties are without any maternity care providers in California. Most counties lack enough providers to adequately care for their regions. In 2022, a report came out from March of Dimes that highlighted large, what they called maternity deserts throughout California, with more areas having limited access. In 2023, even the California Hospital Association disclosed that 20% of hospitals in California might close, with many already shutting down their birthing units to sustain other services. This situation continues to be alarming for families and very dangerous. It impacts consumers during their pregnancies and their births, but also for the rest of their lives and their children's lives. It's not safe. As we know, midwifery care, including licensed midwife care, is an increasingly necessary option for these families who face an increasing time and distance from any birthing facility. Having a skilled provider who can come to you is literally life-saving for these parents and these babies. Midwives are also, however, as I said, experiencing similar reductions in capacity to these facilities, and many businesses are closing altogether. Since the last MAC meeting in September, I've heard from 4 freestanding birth centers that have closed in California, and several licensed midwives have also reached out to me directly to let me know they're closing their practices. I'm hoping that through some conversation today during the meeting, we can get closer to having some sort of plan as the MAC to address some of the more pressing issues for midwives in the state. I encourage the public to continue to engage with the entire meeting. In between the MAC meetings, I'm committed to uplifting the voices of California licensed midwives and our clients to our regulatory body, to the legislature, to other policymakers in any way that I possibly can. If midwives or clients want to reach out to me between meetings, you can find me. Like, you can find my contact information. I can be reached directly. I'm quite accessible. This concludes my report. Are there any questions or comments from the members on the chair's report?
Could you repeat the name of that independent midwifery school that's opening in California?
There are two. Are you referring to Common Sense Childbirth School of Midwifery?
That was it. The other one is based in the community college
Saracosta.
system, correct?
Yes, correct.
Okay, Common Sense.
Common Sense Childbirth. They're out of Florida. They're an incredibly successful program. They center their midwifery education on equity and addressing, like, through a social justice lens, increasing access to midwifery care. So really cool. It's really good news. Are there any other questions or comments from the members on this agenda item?
I just want to say thank you, Madeline, for uplifting and highlighting everything that you just spoke about. Thank you very much.
I've actually only just started. I have another 25 hours, so I hope everyone's shedding. Sorry. Any other comments from the members? It's a pleasure. It's a pleasure. Any other comments, questions? Shall we move to public comment?
If anyone would like to make a public comment on agenda item number 4, you can do so by raising your hand or typing anything in that Q&A window. Give you a few seconds to queue up here. Not seeing any requests at this time, Ms. Weiser.
Sounds good. Let's move on to agenda item number 5, which is an update on midwifery-related legislation from Mr. Bone.
Good afternoon, Madam Chair and members. My name is Aaron Bone. I'm the board's Chief of Legislation and Public Affairs. It's a pleasure to be before you this afternoon. Following the election in fall of last year, newly elected legislators were sworn into office, and legislature began their 2-year session in earnest at the beginning of January. Since then, they have introduced a great volume of bills, which are now in the process of being considered by various policy committees. I did want to note a few bills that may be of interest to the MAC members during my time. The first is to make you all aware that the board is sponsoring legislation to authorize the establishment of a health and wellness program that would offer treatment and monitoring to the board's licensees and applicants related to substance abuse disorders or other health conditions that may impair their ability to practice safely. Last year, the board held multiple public discussions and received input from various stakeholders, including experts who manage similar programs in other states. Our goal is to provide treatment and monitoring to those we regulate before an impaired provider might cause harm to their patient or client. The board's proposal is included within Assembly Bill 408 and is authored by Assemblymember Mark Berman. California is unfortunately one of the few states that lacks such a program consistent with national best practices. Background materials on this proposal are available on the board's website, and updates on this bill will be provided at future quarterly board meetings. The next is AB 55 by Assemblymember Bonta, which was mentioned earlier by Rosanna Davis. This bill does a couple key things. First, it eases the Department of Public Health's licensure requirements to establish an alternative birth center by deleting requirements related to being a provider of comprehensive perinatal services and to the center's proximity to a facility that has the capacity to manage obstetrical and neonatal emergencies. Instead of that proximity requirement, the bill would require the center to have a written hospital transfer policy. That bill also updates a code section that authorizes Medi-Cal reimbursement to alternative birth centers by deleting the requirement that the center be certified as a comprehensive perinatal services program provider. And it states that the center must meet the standards for certification established by the American Association of Birth Centers. Next is AB 836 by Assemblymember Catherine Stefani, which would create a framework to conduct a statewide study on midwifery education. It would be led by the Department of Healthcare Access and Information, or HCI, and the findings of this study are intended to support the creation of a sustainable strategy that will develop the midwifery workforce in California and reflect California's racial, ethnic, linguistic, socioeconomic, and geographic diversity. Among other topics, the bill states that the study shall consider innovations in education and training to allow nurse midwives and licensed midwives to possibly train together with separate exit requirements specific to their path. The next bill I wanted to mention is Senate Bill 626 by Senator Smallwood Cuevas. Among other provisions, this bill requires healthcare practitioners who provide perinatal care to a patient to screen, diagnose, and treat that person for a perinatal mental health condition, according to the clinical guidelines from the American College of Obstetricians and Gynecologists. As currently drafted, the bill would include licensed midwives in this requirement. The final bill, Madam Chair, is SB 669 by Senator McGuire. This bill calls for the Department of Public Health to develop a 5-year pilot program project to allow critical access, individual and small system rural hospitals to establish standby perinatal medical services. The department would be required to consult with a wide range of stakeholders, including licensed midwives, to develop this project. The bill would establish various criteria for hospitals to join the project, including policies, procedures, staffing, equipment, and supplies, among others. This is intended to address closures of maternity wards and hospitals, and states that new models of care are needed to address the needs of birthing people in rural areas who lack adequate access to care. This concludes my prepared remarks, Madam Chair, and I'm happy to try to answer any questions.
Before I ask all of my questions, I would like to know if any of the other members have questions. Okay, so beginning with AB 55, no, just kidding. Beginning with SB 626.
Yeah.
I think it's really great that we have we're working on something that both requires screening and treatment, given that a lot of conversation in the perinatal mental health universe has been about the ethics of screening without the capacity to treat. Can you tell me who is sponsoring this bill and how licensed midwives can partner with them on the fact that we aren't allowed to treat anything or diagnose anything within our scope of practice, and despite like 1 in 5 people giving birth having a perinatal mood disorder, we have the capacity to screen them but not treat them at this point. So
Yeah.
how does that legislation address that?
So I have the fact sheet of the bill up. There are 5 co-sponsors. The first is Black Women for Wellness Action Project. The next is the California Coalition for Perinatal Mental Health and Justice. Next is Maternal Mental Health Now. The next is the Policy Center for Maternal Mental Health. And then the last is PSI California. So those are the sponsors that I'm aware of, Madam Chair. And I'm sorry if I missed one of your questions. I mean, in terms of partnering with them, I be happy to provide you the contact information for the author's office. I'm in dialogue with them on this matter, and had questions for them that I'm still working through with respect to standard of care issues. And I think some of the things that you mentioned, Madam Chair, about how requiring ACOG guidelines to be followed by non-physicians raises a number of questions, to say the least. So, I'm in dialogue with them, trying to better understand, where they're coming from. I do expect that their goals are like what we all share, is to improve access to, high quality care. The bill does include some other provisions related to payment. which, as you know, are not ones that the board, is focused in on. But there are requirements for, health insurers, and I think, HMOs, PPOs, and similar, insurance products to help make sure that these perinatal mental health screenings are, are being covered. I hope that answers your questions. Happy to answer anything else if I missed anything.
This is really cool. Thank you for all of the information on that. I would hope that licensed midwives and stakeholders in the community would lean into contacting those co-sponsors as well as Calm, in the expectation that we get some advocacy on this bill. It sounds like it has the potential to expand the licensed midwife scope, and I would hope that all of the ducks are in a row for that, because that would be really great, actually life-saving. But I'm hoping that people are able to liaise with Calm about this. I think they might be the point people on the licensed midwife specific end for advocacy on it. I did have just a concern on AB 55 that I wanted to say out loud. It's really reassuring to see that there is so much representation from midwives and birth center owners and Calm championing this bill. And I do remain confident that all of these organizations sponsoring the bill are strategically poised to work together on it and navigate any potential changes in this language as it moves forward. But I also wanted to say it's really understandable that a lot of people are looking at any proposed legislation about licensed midwives with concern or trepidation, given the statutory provisions that happened with AB 1308, provisions, compromises, whatever anyone wants to call them, particularly in regard to limits on scope. It's understandable that a lot of people look at any language in regard to time and distance, any language in regard to the requirement of a transfer agreement, knowing how powerful lobbies tend to influence the language of these bills. And so I'm saying it out loud so that our trade organization and the medical board can both hear it, that everyone's being watched very closely on AB 55, and we want a successful bill that will keep birth centers open and allow more birth centers to open without limiting the scope of what licensed midwives are able to do, just for clarity's sake, SB 669, this is the Plumas model, correct?
I don't know the answer to that, unfortunately.
Okay, I think that it's a pilot for critical access standby perinatal medical services. So in areas where they don't have a 24/7 OB service, such as in Plumas County, it would provide for those standby services to be available. So let's say someone is birthing at home with a licensed midwife. They need to go to the hospital. They need to transfer to a hospital. That would allow that hospital to assemble quickly a team that could provide them obstetric care. I'm pretty sure that this is the same thing. Pretty sure this is the same thing. Okay. And then with Stefani, AB 836, am I correct in hearing that there is talk about this making space for nurse midwives and licensed midwives to be trained together and then have different exit pathways?
That is from the bill. So yeah, so there are, looks like 14 criteria for the bill at minimum, for the study at minimum that are called for in the bill. And one of them is to consider innovations in education and training to allow nurse midwives and licensed midwives to train together with separate exit requirements that are specific to each path.
Cool,
So.
sick. That's great. Awesome. Are there any other comments or questions from the MAC members?
I have a question, Mr. Bone, if you have a moment. For
Yes,
AB 55, could you help clarify for me whether or not this transfer, the steps that would replace the 30-minute requirement would be a transfer plan or a transfer agreement that would require an agreement signed by a hospital to receive transfers?
Great question. I haven't done all the research on it, but you know, the language references a couple of other sections of the Business and Professions Code stating that there must be a written policy for hospital transfer. The code sections reference, and it mentions a couple of paragraphs, but those code sections are 2746.54 and then also section 2508 of the Business and Professions Code. So I haven't looked at those in greater depth or detail, but that's what's called for in the bill.
Okay, thank you. That sounds like a plan, not a requirement for an agreement in which the hospital would agree to accept transfers or make some other written agreement with the midwife or the practice or the birth center. Is that how you read it? It sounds like you're looking up the
A little
code.
bit more time to, unfortunately, to get you get you some more information. But 2746.54 is a section that's in the Nursing Act, so that pertains to the certified nurse midwife. And let's see, it speaks there to paragraph 6 and 7. So paragraph 6 of that section says, talk about specific arrangements for the referral of complications to a physician and surgeon for consultation. The certified nurse midwife shall not be required to identify a specific physician and surgeon. And then paragraph 7 talks about, and the context of this is an informed consent agreement between the nurse midwife and their patient. And then the other paragraph there speaks to specific arrangements for the transfer of care during the prenatal period, hospital transfer during the interpartum, postpartum periods, access to emergency care. So it does sound like, as you indicated, that that's a plan, not necessarily an agreement.
That's very helpful. Thank you.
Yeah, and then if you have
like this is almost a carbon copy of the licensed midwife requirement that was instituted by AB 1308. Because we have this as well. I wonder why they reference the nurse midwife one and not the licensed midwife one, if there's like some
I was getting
itty bitty
there.
nuance there.
Yeah,
Yeah.
it is also in there. So it does reference 2508, which is in the Licensed Midwifery Practice Act. And paragraphs 8 and 9 read very similarly to the certified nurse midwife language that I just referenced. So arrangements for referral of complications to a physician, and then specific arrangements for the transfer of care during the prenatal period, hospital transfer during the interpartum and postpartum period, emergency care, and whatnot. I hope that's helpful.
That's really helpful. Thank you.
Yeah.
Thank you so much.
My pleasure. Are there any other questions I can answer for the members?
Questions? Thank you.
Yeah.
Are there any public comments?
Anyone like to make any public comments here on agenda item 5? Please do so by using the hand raising feature. Type anything in that Q&A window. Give you a few seconds to queue up. Not seeing any requests at this time.
Okay, let's move on to agenda item number 6. I will be providing a report from the task force on Medi-Cal related issues. My report is as follows. I am continuing to advocate for equitable processes for licensed midwives providing care within the Medi-Cal system. That the number of licensed midwives providing care within the Medi-Cal system decreases every day. First, I wanted to take a minute to talk about the advocacy efforts through MACA, which have led the Department of Healthcare Services to make critical updates to the non-physician medical practitioner manual. The non-physician medical practitioner manual, albeit very goofily named, does give guidance on the scope of practice of the licensed midwife benefit in the Medi-Cal program. And they're talking about changing the name, just so everyone knows. These updates do include a revised coding list in the covered services section for licensed midwives. This change is a small piece of streamlining midwifery billing processes in the Medi-Cal system and ensuring that all services within the scope of midwifery practice are recognized and reimbursed. Updating this manual also compels managed care organizations who are administering Medi-Cal benefits to get up to speed with their provision of this benefit, which I will remind you all is a guaranteed covered benefit for all pregnant people and all newborns with Medi-Cal coverage. Some of the codes that have been added to the manual include home and office visits, life-saving medications and equipment, complementary and alternative therapies routinely used by midwives, routine health screenings, newborn care, prolonged outpatient visits and care, telehealth services, counseling and education. Hundreds of codes have been added to this list. These additional codes both increase overall reimbursement and allow Medi-Cal program to better capture data about the care provided by midwives in its system. The process by which MACA has compelled DHCS to make these changes has been really cool to participate in, honestly. And I want to be clear that any successes that licensed midwives have had lately in increasing this codes list have been due to our nurse midwife colleagues. They're the ones who showed up and centered the needs of licensed midwives in all of these conversations, refused to get anything done without us, basically. And they have used a lot of their available resources to get us what we need from Medi-Cal, which is very cool. DHCS is also now working to incorporate the licensed midwife benefit into their annual utilization audits of managed care organizations. This inclusion is expected to encourage the Medi-Cal plans to prioritize access to midwifery care for their members. By examining the utilization of licensed midwife care during these annual audits, DHCS has another tool to hold the plans accountable for denying this care. And hopefully this will foster more interest in ensuring that midwifery care is accessible and adequately supported. DHCS implemented targeted rate increases for licensed midwives effective for dates of service on or after January 21st of last year, making the reimbursement for a vaginal birth a whopping $544 for the birth itself. The emergence, right? Although this is an increase, we can all agree that utilizing this increase with the expanded codes list in addition will allow licensed midwives to possibly scrape by, not thrive. Medi-Cal reimbursement rates for licensed midwives, and in fact, all maternity care providers, are an ongoing embarrassment. And it does seem that the private insurers are engaged in a race to the bottom with lower reimbursements than ever coming from most insurers these days. Finally, I want to talk about the Birthing Care Pathway, which is a statewide initiative by DHCS to improve maternal health and birth equity for pregnant and postpartum Medi-Cal members. This pathway addresses disparities and ensures access to care from conception through 12 months postpartum. The pathway aims to decrease maternal deaths and complications through evidence-based interventions and improved care coordination. The pathway specifically addresses racial and ethnic disparities in maternal newborn health outcomes. It seeks to enhance access to a comprehensive spread of maternity care providers and services, including midwives, physicians, doulas, regardless of location or provider, and improve coordination across different care settings. The design of the pathway is shaped by input from Medi-Cal members with lived experience in the Medi-Cal program, ensuring that their needs and preferences are centered. Licensed midwife services were also included in this pathway more than they've ever been included in anything printed by Medi-Cal in history. And the department has expressed repeatedly that it's open to receiving feedback about how the midwifery benefit is shaped. So that is my Medi-Cal update. I feel like it's overall pretty good news. But are there any questions or comments from the members about this agenda item?
Yes, I have a question, and pardon me if I just missed something that you did say. With the MACA updates for the non-physician medical practitioner manual, what is compelling the plans to follow these guidelines? I'm sorry, I didn't quite get that part.
Well, they make it complicated for a reason, I'll tell you that. But basically, the way that licensed midwives are a Medi-Cal benefit, the reason for that is that licensed midwife services, which are defined by everything under the legal scope of licensed midwife care, those were added to the state plan. And the state plan is everything that Medi-Cal has to cover. Managed care organization, so managed like health plans, get money from Medi-Cal to administer Medi-Cal benefits as a middleman. They pocket a lot of that money, okay? But they take their money and they use it to pay for services. They are required to provide access, equal access to everything on the state plan. So if fee-for-service Medi-Cal covers something, the managed care plans also have to cover that. The member has to have equal access to that. And we have proven time and time and time again that a lot of these health plans are being really naughty and they're refusing to cover these covered guaranteed benefits, right? And so those members, in order to access those benefits, have to do all this paperwork. They have to go in front of a judge. They have to get their midwife to put her neck out on the line for this and usually front the cost of the care until, you know, the managed care plans and Medi-Cal get their like poop in a group about paying the midwife, right? And midwives are amazing, so they do this, but MACA has been able to further clarify what the rules even are about it and compel the managed care plans to get on board with this by making the rules from fee-for-service Medi-Cal much more clear about what they have to do. So initially, we didn't want a codes list. Initially, we were like, no, it should just reference the Business and Professions Code. And that's all. And the plans prove to us that they have no idea how to interpret that or read that, and that we had to outline every single service we provide. So there are codes for like the use of a pool. There are codes for like targeted massage. There are codes for driving to the patient or the client's home, you know? We had to outline every single little piece of what a midwife does for their clients, right? And now it's all in there. The next kind of step is going to be getting them to just name it the midwifery manual instead of the non-physician whatever.
So you're saying
Finding
these
us
codes
by what we're
are
not.
are already like legitimate codes, or are they still just like, these are the codes we propose and they need to be adopted, or they already are in
Oh,
the
they're in there. They're in
active
there.
billing system?
Yeah, and you're
Okay.
supposed to be able to bill them if you're a Medi-Cal provider. But that was one of the initial steps to compelling the managed care Medi-Cal plans to also reimburse for those. So it's the first of a lot of steps, but it's a big hot deal, particularly for people with Medi-Cal who don't have a managed care plan. So these would be some undocumented families who are seeking midwifery care. They are in fee-for-service. People who have aged out or are within the foster care system or have aged out of the foster care system often will have fee-for-service Medi-Cal still. There's been a huge shift over to the managed care plans like in the last couple of years, but some people who have pregnancy-only Medi-Cal will have fee-for-service, and all Medi-Cal beneficiaries who are not able to access a midwife through their managed care plan can switch back to fee-for-service. They have that right because they're not getting it from their plan, right? So it gives those folks a pathway to do that as well. So it's
Thank
not the
you.
end of the Medi-Cal thing, but
It's a huge step. Yeah.
progress. Yeah. And midwives are starting to get back pay from those targeted rates increases as well. So from fee for service, as well as some of the plans are starting to pay that back pay. They got the memo that they have to do it and they're finding that money somewhere, you know? So we're getting there. Are there any other questions or comments from the MAC members?
Amazing work. I see how hard you have worked to educate yourself and everybody else in this very convoluted, complex, and often thankless mycelial web of knowledge and incremental movement. And I really appreciate it on behalf of maybe all the people who haven't been able to say thank you. Let me speak for our other midwives. Very impressive. Thank you.
Any other questions, comments? Shall we move to public comment?
Anyone who'd like to make a public comment, you can do so by using the hand raising feature or just typing anything in that Q&A window. We have a few seconds here. First up here, we have Rosanna Davis. Rosanna, you should be receiving that prompt on your end again.
Yes, Rosanna Davis. I would first like to echo Ms. Weisner's acknowledgement of the nurse midwives for advocating for licensed midwives in many of their initiatives in education, policy, and the legislature. It really has made a huge difference, and it's greatly appreciated. And we continue that collaborative work. And secondly, I'd like to thank Ms. Weisner for her ongoing advocacy in the Medi-Cal access arena. She's been tenacious about it, and it is very complicated, as pointed out earlier. And I appreciate your tenacity, Ms. Weisner.
All right, thank you for your public comment. Checking here just to make sure, but yeah, at this time I don't see any additional requests.
Cool. Awesome. Let's move on to agenda item number 7, which is program update from Ms. Moore-Erdy.
Thank you. Please turn to page 7A1 for the midwifery program licensing statistics. In the first quarter of fiscal year 2024-2025, the board received 9 new applications, issued 8 new licenses, and renewed 50 licenses. Please turn to page, in the second quarter of fiscal year 2024-2025, the board received 10 new applications, issued 8 new licenses, and renewed 58 licenses. Please turn to page 7B1. In the first quarter of fiscal year 2024-2025, the board received 45 transfer of planned out-of-hospital delivery to hospital reporting forms for licensed midwives and 62 in the second quarter. Please turn to page 7C1 for enforcement statistics for licensed midwives. In the first quarter of fiscal year 2024-2025, the board received 6 complaints and referred 0 for investigation. In the second quarter of fiscal year 2024-2025, the board received 5 complaints and referred 5 for investigation. Please turn to page 7C2. In the first quarter of fiscal year 2024-2025, the board received 1 complaint for unlicensed midwives and 0 were referred for investigation. In the second quarter of fiscal year 2024-2025, the board received 4 complaints for unlicensed midwives and referred 3 for investigation. Please turn to page 7C3 for enforcement statistics for transfer of planned out-of-hospital delivery to hospital reporting forms for licensed midwives. In the first quarter of the 2024-2025 fiscal year, 55 transfer of planned out-of-hospital delivery to hospital reporting forms were closed by the board and 0 were referred for investigation. In the second quarter of the 2024-2025 fiscal year, 70 transfer of planned out-of-hospital delivery to hospital reporting forms were closed by the board and 0 were referred for investigation. Please turn to page 7C4. In the first quarter of the 2024-2025 fiscal year, the board received 3 transfer of planned out-of-hospital delivery to hospital reporting forms for unlicensed midwives and 0 were referred for investigation. In the second quarter of the 2024-2025 fiscal year, the board received 5 transfer of planned out-of-hospital delivery to hospital reporting forms for unlicensed midwives and 0 were referred for investigation. Thank you. That concludes my update. Are there any questions?
I have a quick question. It seemed like on that last page, can we flip back there?
Sean, can you go back to the last 7C4?
Thank you. So I see no cases in fiscal year, let's see, 24-25 Q2 were referred for investigation, but one was referred for criminal action to, I would assume, the Attorney General, even though the Attorney General is not on here. Can you specify what the difference is between investigation and referred for criminal action for these unlicensed midwives?
Carrie, can you answer that question?
Yes. So the first thing I want to make clear is that the what is referred may be from another quarter. So the complaints and the actions taken may not be on those complaints from that quarter. With what's referred for criminal action, the board can issue citation and fine, but to do further, it's actually a crime to engage in unlicensed practice. And so those matters are handled by district attorneys.
Okay, that answers my question. Thank you very much.
I have a question. Do you feel like fewer of the transfer forms are being investigated than in years past? Do you notice? Do you see this?
I would have to go back and look at the statistics to give you an answer on that. I don't know the answer to that.
Let me rephrase my question. Do you feel like there have been any like notable trends in investigations of licensed midwives lately that you could share? Or investigations of unlicensed midwives?
I would have to go back and look. I'm sorry, I don't know. I can,
That's,
if you
it's
want
not
me
something
to,
we
go
we
ahead,
would
Carrie.
want to answer it on the fly. You know, we have probably, you know, anecdotal thoughts, but I think, you know, that's a question that merits a careful review to provide accurate information.
Understood. Thank you, Ms. Webb. I have one more question. Are you able to share how many midwives have submitted the LMAR this year? I know that it was due on the 30th, right?
Correct. I don't have the reports yet. The final report is run by HCI on July 30th. So I will have more information on that at our September 11th meeting. I can give you all of that information. So we do allow for late reporting up until the report is run in July 30th. So I will have that information at the September meeting.
Cool. And just to clarify, midwives who perhaps it slipped their mind submitting the LMAR before that deadline could still submit it?
Yes, they can. And they will be getting a notice. If there is a midwife that did not report by the March 30th deadline, they will receive a notification that a hold will be placed on their license, on their renewal, if they don't submit that report in time within this year.
Okay, cool. Thank you.
Thank you.
Are there any other questions or comments from the members? Shall we move to public comment?
If anyone has a public comment about agenda item here number 7, please go ahead and use the hand raising feature, the Q&A window. We'll get you called upon. Give it a few seconds to see if anyone queues up. Okay, I'm not seeing any requests at this time.
Sounds good. Let's move on to agenda item number 8, which is the selection of one new MAC member to fill the public member vacancy. Ms. Moriarty, please update the members on the application received for
Thank
this
you.
long vacant position.
Yes, thank you. In September of 2024, the medical board posted a recruitment announcement on its website for one public member position on the Midwifery Advisory Council. This position is for a 3-year term that will expire on June 30th, 2028. The board received one application for the public member position from Karen Rosley. Ms. Rosley, would you like to provide a statement?
And Rosalie, there's a mute button down there at the bottom you probably have to hit.
There we go. A statement. Well, I am a consumer member of Midwifery Care. I had my child in a birthing center, and I have also worked with midwives for close to 2 decades, and I have a midwife as a mother, and I firmly believe that they can answer a lot of the health issues in our culture, and I do believe they are underappreciated. And I think there's a lot of roadblocks to working within the system in a more functioning manner that's actually better for consumers, because people are not going to stop seeking midwifery care. Hospitals are not going to get everybody to go to the hospital. They're going to keep doing it. So the goal should be to figure out ways to make it safe for those consumers. So I guess that's my public statement. Thank you.
Thank you, Ms. Rosley. At this time, the MAC may discuss and make a nomination to recommend the applicant for the public member position to the full board.
Would anyone like to make a nomination to recommend Ms. Rosley to the full board to be seated on the MAC?
I just have a
Okay.
question. You said there was only one application that was put in. When I have a couple of colleagues who also put in applications and who were in contact with Miss Tanya.
Yes. So some applications were received, however, not all applications qualified. So I was in communication with anyone that submitted an application
I see.
that didn't qualify. Yes.
Okay. Well, I'll recommend Miss Karen for the board.
Awesome. And we don't even need a second. Ms. Moriarty, please perform the roll call vote.
I think we need comment from the members and
Oh,
public comment, please.
Yeah.
Yes.
Okay.
Thank you.
Do we have any comment from the members? Other comment? I'll say that I've worked in similar spaces to Ms. Rosalie for years, and I had recommended that she join the MAC because she is extremely well spoken about midwifery care and the challenges that we face. She has like a lot of experience on the consumer advocacy front, as well as helping to run a like midwifery business and practice, and she's kind of seen a lot of sides of it. So she has my like strongest endorsement.
And I'll also say that I took a look at your resume, Miss Karen, and your letters of recommendation, and I feel confident in my recommendation based off your resume and the recommendations alone.
No further comments. If anyone would like to make a public comment, go ahead and take that. If you'd like to use the hand raising feature, type anything in that Q&A window. Give you a few seconds here to queue up. First up here, we have Rosanna Davis. You should be receiving that prompt.
Yeah, Rosanna Davis. Just a quick thank you, Ms. Rosalie, for stepping up for this. It's very much appreciated.
Great, thank you for your public comment. Just verifying here real quick. Doesn't look like there are any additional requests in queue.
Okay. Now, Ms. Moriarty, could you please perform a roll call vote?
Yes.
Thank
Faith
you.
Freeman. Faith Freeman.
Yes.
Tamara Robertson.
Yes.
Mason Wilson Teneb.
Yes.
And Madeline Weisner.
Yes.
Thank you. The nominee, Karen Rosley, will be presented to the full board at the May 2025 quarterly board meeting for final approval.
Awesome. The motion carries. Hey. All right, let's move on. Thank you. So excited. Let's move on to agenda item number 9. Presentation on midwife access to audiology equipment for newborns from Ms. Wilson Tanev. Take it away, Mason.
Oh, thank you very much. Let's see. In California, the Newborn Hearing Screening Program, NHSP, overseen by the Department of Healthcare Services, mandates that all general acute care hospitals with licensed perinatal services perform hearing screenings for every newborn prior to discharge. These screenings must follow department-approved protocols and be conducted by a licensed physician, registered nurse, audiologist, or other appropriately trained individual under the supervision of a licensed healthcare professional, according to the California Health and Safety Code 124-1165. While the California Code of Regulations, Title 17 for brevity, does recognize licensed midwives as out-of-hospital newborn screening providers for the purposes of metabolic screening, it does not explicitly authorize them to conduct audiological screenings. This omission creates a substantial and unnecessary barrier to care, particularly for families choosing community-based midwifery services. It's important to recognize that licensed midwives in California are already performing newborn hearing screenings in out-of-hospital settings. Many of these midwives have acquired the necessary equipment, obtained appropriate training, and are fully capable of conducting otoacoustic emissions testing in accordance with professional standards. However, insurance providers, including Medi-Cal, frequently deny reimbursement for these services, citing either regulatory ambiguity or the absence of a recognized billing code for midwives providing this form of screening. As a result, families who decline hospital-based care or are geographically isolated often bear the full cost of services, or in many cases, they go without screening entirely. This issue is further exacerbated by the broader context of institutional mistrust that's growing and growing. In the current cultural climate, a growing number of families, particularly those from historically marginalized communities, actively avoid hospital and clinic-based newborn care due to previous experiences of discrimination, coercion, or inadequate culturally competent care. These families are often highly motivated to adhere to the recommended screenings if provided by their trusted midwife, but may forego testing altogether if it requires a separate visit to a hospital or to a specialist. In rural and frontier areas of California, access to pediatric audiology services is already very sparse. Some hospitals refuse to screen newborns not born in their facility, requiring parents to seek care from pediatric audiologists or ENT specialists. These providers often charge specialist fees that place care out of financial reach for many families. The result is a widening disparity in the early detection of congenital hearing loss, a critical public health concern given that early intervention significantly improves language, social, and cognitive outcomes. Licensed midwives are already entrusted with critical aspects of neonatal care, including physical examination, congenital heart disease screening via pulse oximetry, and metabolic screening. The exclusion of audiological screening from their scope, particularly in the absence of a compelling clinical rationale, is inconsistent with both their training and their role in the perinatal care continuum. So, how do we fix this? Our next steps. Today, I will be submitting a petition to amend the language of Title 17, the DHS, to California Association of Licensed Midwives, California Nurse Midwives Association, California Medical Association, California Academy of Audiology, California Coalition for Newborn Screening, and the California Conference of Local Health Officers, and MACA, as well as to interested licensed midwives. And after a review period by stakeholders, the petition will be submitted to the Department of Healthcare Services to amend the current language to remediate the gap. Therefore, I respectfully request that the Medical Board of California publicly acknowledge and support the role that licensed midwives already play in conducting newborn audiology screening, particularly in out-of-hospital settings, that the board support legislative and regulatory efforts to explicitly authorize LMs to perform newborn hearing screening under the NHSP, that they advocate for the establishment of appropriate billing codes and reimbursement pathways for midwives conducting such screening to ensure equitable compensation and reduce the financial burden on families and midwives, and to encourage the Department of Healthcare Services to integrate midwives into the broader newborn hearing screening infrastructure through the provision of training, equipment grants, and data reporting tools. And addressing this gap will significantly advance health equity, improve early detection of hearing loss, and assure that all California newborns, regardless of their place of birth, receive timely and comprehensive care. The inclusion of midwives in this domain is not only medically sound, but also socially responsive and fiscally prudent. Thank you.
Thank you. Any questions or comments from the members?
I just want to say thank you, Ms. Mason, for uplifting this. I've been looking forward to this since you put it on the agenda during the last meeting, and it is beautiful. Thank you so much for your passion.
Yes, just to echo that, I'm really excited to hear the next steps that you have already been orchestrating, and I'm excited to keep helping in there. I would like to help. That's also if there's anything I can do as well to support this process. And I appreciate all the work you've put into it.
Yeah, really
It's a simple
incredible.
fix.
It's really great how you've put this together. Like it's been a simple fix, but no one's done it. So thank you. Thank you so much for everything you're doing. Really, really cool. Any other questions, comments from the members? Awesome. Shall we move to public comment?
Yes, if anyone would like to make a public comment on agenda item 9, do so by raising your hand or typing something in that Q&A window. Give you a few seconds to see if anyone would like to queue up. Not seeing any requests this time, Ms. Weisner.
All right. Cool. Thank you so much. Let's move to agenda item number 10. This is a discussion on accessibility and sustainability of California midwives. And I'm going to kind of lay out my idea here. I have some information that I want to share with the MAC. And then my idea is that I have these 3 questions that I'm going to say and ask for you guys to respond to. And I'm sorry that it's on the fly. I couldn't find out a way that I could do this and like be allowed to send them ahead of time. But this was an agenda item, so I want to do it, right? So my idea is that I share this information, I ask these questions, and then I can restate the questions once it's time for public comment. But my understanding is we can't have back and forth in the meeting between members and the public commenters, despite it being labeled a discussion. So my idea would be that we take the public comments that are made last into account for further work on this in between meetings, as well as for subsequent agenda items today and at future meetings. But if that sounds like a really bad idea, please say something. Because I don't know if there's a possibility, like I don't know what the pathway is for like an interested parties meeting about this, but the last few meetings people have wanted to discuss this, and I'm trying to make it within the confines of like Bagley-Keene open meeting stuff. So so I guess blink twice if that sounds okay, or I'll just keep going. You can't even respond. Okay, great. Sounds good, everybody. So here we go. Only 24 hours to go. So California midwife workforce practice setting work environments and future practice plans is a document published by California Healthcare Foundation. It was published at the end of the year, October 2024, so it was published since our last MAC meeting. And while it does discuss nurse midwives and licensed midwives, it often compares and contrasts them. I want to keep our discussion focused on the licensed midwife portion, and I'm gonna like tell you the greatest hits of the report too. Because of the format of these meetings, it can be difficult, but I want for us to consider this discussion to be like groundwork to foster an actual real conversation among all the stakeholders and work it into the next agenda item, which is like making a presentation to the medical board on behalf of the MAC about this. Does that make sense? Hopefully that makes sense. So first, I wanted to share some of the key points from the CHCF report. You can find it online too. But so between 2017 and 2023, the number of LMs licensed in California increased by 22%. In 2023, there were 458 LMs with an active California license and California address. In 2023, more than 3 in 4 licensed midwives were practicing midwifery. And among LMs not practicing, stress was a cited reason, important reason for not practicing. 62% of licensed midwives in this report practiced in their own individual midwifery practice, and about half worked in sole proprietorships. You guys with me? 2 in 3 LMs said they do not have malpractice insurance. Those without malpractice insurance most often reported that high cost was the reason, with the second most commonly reported reason being a lack of insurance policies that offer coverage to LMs. So it's not necessarily that they were ideologically opposed to having malpractice insurance, although some midwives definitely are. Although most midwives reported being satisfied with their careers, a significant portion planned to take breaks, leave the profession, retire, or reduce their client load in the next 5 years. There are currently no accredited midwifery programs for LMs in California. It sounds like 2 are coming in the fall of 2026. On to demographics. 12% of licensed midwives identify as Latina or Latinx, while 45% of the state's population of birthing people of reproductive age are Latina or Latinx. 2% of licensed midwives in the report were Black, compared with 6% of birthing people of reproductive age. 25% of LMs said they spoke a non-English language fluently. Licensed midwives estimated that 6% of their patients or clients preferred to receive services in a non-English language. In regard to job satisfaction, 2 in 3 licensed midwives said they were very satisfied or satisfied with their midwifery careers. 1 in 3 practicing LMs planned to take a temporary break from midwifery work, leave midwifery work entirely, retire, or decrease their clients in the next 5 years. So it's a lot of information, right? But you get the gist of it. Like, licensed midwives like their jobs, want to keep doing them, want to keep providing culturally responsive care, and also want to stop. A lot of them want to stop or feel they have to stop with few replacements available, without the capacity to replace themselves. So once again, my idea is that I have these 3 questions that I'd like to ask one at a time, and I'm going to put you all on the spot and have you answer or provide insights. And then I can restate those questions again once it's time for public comment. But my understanding is that we can't have the back and forth between us and the public, despite that being like kind of what's necessary here. So we could do us and then the public, and then next time do us again, and we'll have notes. Okay. So first question. Given the substantial increase in the number of licensed midwives in California, how can the MAC better address the needs and challenges faced by midwives who are practicing independently? So what can the MAC do to better address the needs and challenges of midwives? Does anyone have anything they'd like to say?
So it really sounds like you've identified, and in your previous presentation at the last MAC meeting, you really identified some of the stress points, which would be And I think that the number one, if I remember, it was a long time ago, but we really identified that a lack of cohesive payment structure from insurance companies seems like it's the biggest barrier to providing sustainable care. That seems reflected in my experience as well.
I guess I would say that like the amount of money that midwives need to be able to work is not the amount of money that families can pay or should be asked to pay or can pay. And it's not the amount that insurers are willing to pay. I think this is like 5-digit math. You know, like this number is less than this number. I think that's the root of like the material stuff. And so I'm wondering how the MAC is poised. Like, do we just keep talking about that? Do we just keep talking about it, or do we are we allowed to issue a statement?
I'm glad you're asking this question, Ms. Weisner, because this has been my question as well since becoming a part of the MAC, is just what is our role and how we can utilize this body to get more action done in California. So I'm not sure I have the answer to your question, but I am also asking that same question and would love to discuss further.
Yeah, and I just want to mirror what Faith just said. I think this was a question last MAC meeting, was what can we do? What do we have the power to do as a board? And to my understanding, we are to make recommendations to the medical board. But I don't know what, I feel like we're down to do whatever we need to do, but what can we do? Right? Even, you know, you come with the reports, you come with the presentations, they're always so informational, you know, everything is facts, right? So what do we do about it? Outside of the advocacy that we're doing here on this call.
I kind of want to know what Marty and Ms. Webb think. I mean, I definitely want to know, but I want to know what, like, if we can enlist them to give some real clarity on what we're allowed to do. And I tried to learn this. I've done a lot of like, what can an advisory council actually do? Type like Ask Jeeves ing. You know, and I'm not getting answers. I'm not able to find like the statutory authority on what advisory councils in California are actually allowed to do. So would you be willing to chip in a little bit?
Sure. I mean, I think you've identified yourself as an advisory body, and so that is what you're able to do to the medical board is make recommendations for certain actions. You know, certainly these public meetings highlight areas of concern and obviously has the attention of CALM and other interested entities and parties who can on their own make legislative recommendations. Certainly some of the areas that you've brought up, other entities besides the board have a lot of control over the issue of payment. And but you know, certainly items dealing with the Midwifery Practice Act and changes that need to be made to the Midwifery Practice Act, that is certainly within your role to recommend those changes be made, recommend to the board that those changes be made, and then the board can decide whether to seek legislation. And just a reminder, you don't have to have the board to seek legislative change. You can't do that as the MAC, but as individuals and as outside entities, you can do that. But if you want the board to be involved in trying to find an author for legislative change, that's a recommendation that you would make to the board.
Okay, so to clarify, we could make a recommendation to the board that's like that is recommending that the medical board promulgate regulations that are in line with
Yes,
what we
if there's statutory authority for the regulations for the medical board to do. Some of the regulations you're going to be seeking, they're not within our title. So
Right.
Title 17, that's different than Title 16, which is under the medical board's authority. So, understanding what entity has control to further those regulations will be important. And, certainly I can try to help identify pathways if that's
Cool.
helpful. So, and then, making sure that the authority to do it is there and that the finances required to do it is there. This is all part of the discussion on the changes that can go through the board.
I guess that the impression that I had was that we could make recommendations to the medical board, but recommendations for legislation would need to be made to the legislature or like chopped, Is what you're saying that the MAC theoretically could make recommendations to the medical board and the medical board could chop those ideas for us on our
Yes,
behalf?
if the board agreed. For example, the board supported LMs having their own board.
Right.
That was part of our sunset on 2 occasions. That's an example of how we work together to try to further a significant change.
Right.
But if there's additional legislative changes within the Midwifery Practice Act, you can put forward those ideas for consideration, and staff would do an initial review to determine whether it's actually within the Practice Act, and it would be up for discussion for the board to decide whether efforts and resources would be put toward making the requested change.
This is really great news. Thank you. My final question for you, Ms. Webb, before we move on, is the licensed midwife annual report, the statutory authority for that, is that within the Licensed Midwifery Practice Act?
Yes.
Awesome. Thank you. Perfect. Okay. We'll come back to that later. So to kind of, thank you, Ms. Webb, to kind of repeat this initial question of how can the MAC better address the needs and challenges faced by midwives who are practicing independently, our sole proprietor midwives. Are there other things that MAC members would like to specifically note? Thoughts they've been thinking?
Could I get back to you on that?
I don't know. Yeah, I think so. Like you individually could, and we can keep it close to the vest before the next meeting. As long as it's between me and you, I'll add it to the notebook.
Okay, is your
I think that's
question
allowed.
what other questions might I have as a MAC member about how to work in best alliance with the medical board to promote legislation or information education that would support licensed midwives?
I mean, that wasn't my question, but we can go there.
Oh,
I like
I have a lot of questions. I just learned a lot
skipping
from
what you're
Ms.
pulling.
Webb.
I think that my question was how like by what methods can the MAC better address these needs? And it sounds like we have more options than we realized as far as making recommendations to the medical board to pursue certain legislation or certain statutory changes, right? I guess I could go on to my next question. Is there anything that the MAC would consider doing that specifically would address or promote sustainable midwifery practice in California? Perhaps that addresses midwives' well-being while maintaining access to these essential services. I know that Mr. Bone mentioned the provider wellness program, right? So that's available to licensed midwives, or will be available to licensed midwives. Are there other things that the MAC can create or promote within ourselves that could be disseminated by the medical board for midwives specifically? I'm wondering if anyone has thoughts about that.
The medical board could come out and positive support of a legislative expansion in California to legalize psychedelics for not just veterans use, but for the wellness of providers as well, given the amount of science that is behind this idea. And they would have to work with the governor's office to make sure that something like Treat California comes through, or that the governor does not veto another bill. So to have their alliance in legislation that's coming forth to protect veterans, but also to protect healthcare providers, we know are a very vulnerable population as well, would be an incredible show of alliance and leadership. They would be, yeah, that would be a tremendous amount of leadership from them.
This is interesting. I was not expecting you to say that. That is very interesting. I'm adding it to the list, and I want more information from you. Let's see. I would love to hear from Ms. Freeman and Ms. Robertson.
I think my question, or like what's in my mind, is maybe for Ms. Webb as well, but like, what is our best ways of communicating with the medical board? And I know one of the other agenda items that we're about to get to is the presentation for the medical board, but also would just love some more clarity on how we are to communicate and how that looks, and if there's multiple ways, because I think that would also play into all these questions you're asking, Madeline.
Well, the main way for the MAC as a body to communicate with the board is through Ms. Weisner's reports. Additionally, we've had the representatives from the MAC do presentations to the medical board in the past on a variety of topics. So that is another way. And as individuals, so not as the MAC, but just as individual stakeholders, the board has public comments on items not on the agenda the first day of the 2-day meeting, so Thursdays, and on every agenda item after that. So if there's a topic that people are interested in, you can participate in public comment. So that could be on legislative matters, when a MAC representative provides a presentation to the board, public comments on that agenda item, and any item of interest.
That's very helpful. Thank you. When you're saying the medical board, we're communicating with them through Ms. Weisner's reports, are they being emailed the minutes from the meeting, the reports? Like, how is that? Or I'm unclear on that communication.
There's a written report, and Ms. Weisner appears virtually at the meetings. So far, virtually, but would be welcome in person as well.
And also, theoretically, the members of the medical board can ask me questions, but they never do. It's really like they kind of move through it quickly. I'm sure if I had something more like stimulating to share, they might engage more. But it's usually like, this is what we did at the last MAC meeting. Please approve our new member.
Okay.
May I have a motion? Thank you. Bye. You know?
So in the reports, it's the scope of that is just providing them the basic overview of our meetings. You're not able to dive into the different topic of reports like you are with us, it doesn't sound like.
I am given a report to read them that is like a brief summary of what we discuss at the MAC meetings. I'm sure it's going to be a little spicier after the last couple. It's been a little bit. And also we as a MAC have an option of like having someone present to the medical board. So historically, Claudia Brelia presented to the medical board itself, not just the MAC, the medical board, about VBAC. And that was really freaking cool. And the MAC hasn't had anything like that for a while. So that's one of our forthcoming agenda items, is to be like, what should we tell them? We could tell them about what we talked about, or we could put together something really specific, like a list of demands, and see what they have to say or do about it, you know?
Well, I think just a suggestion, because this is an advisory board. So
right.
You know,
Advise.
I suggest that you work with staff. The report from the MAC, it is pretty straightforward. I think you're right, Ms. Weisner, that there would be more engagement if there was a separate item for discussion. I think they're taken the report from the meeting, and that they routinely grant authorization for the next agenda's proposed topics, and so far.
Right.
So, but yeah, I encourage you to work with staff on ideas for communicating with the board.
Right. And to be clear, staff has been like really helpful and lovely about this, and willing to hear all of the ideas, obviously, and give us like meaningful steps forward with this. So I really do appreciate all of you and your time, of course. I know that in the past, the MAC has made recommendations to like make certain updates to the medical board website or documents that are available. Is that still an option, or is that something that we can discuss and vote on at the MAC meeting, or is that something I can contact staff about individually just to see if you guys can tweak it without us having a whole meeting about it?
Yeah, both of those things. So if there's something that is incorrect, outdated, that staff can independently verify, then anyone can point out, take a look at this.
Okay.
If it's something where there needs to be further discussion by the MAC, or you want to get additional input on, if there's additional information that can be included, then set it as an agenda item.
Okay, great. Thank you.
Right. And, not, some things do require board approval, and some things, it can be addressed by staff. So
cool.
We're happy to help with determining path forward if you have ideas on that.
Great. Really cool. Thank you. Other thoughts that I had on this are to invite someone to speak at a MAC meeting about other models of midwifery practice, including case loading midwives, group practice models, things that can keep midwives working when they would otherwise quit or change their professions. I had someone reach out to me recently, and they're a California licensed midwife, like fully trained. They have a degree, and they are working as a medical assistant for 1/5 of the wage that they should be making, because midwifery practice is just so darn hard. And I think that the MAC is uniquely poised to invite people to talk about other ways that they could like stay in business or keep working or sustain themselves. That being said, we have 10 attendees, so perhaps some sort of engagement tactic might be what we could do first, but just to get midwives to these meetings. Granted, it's been 2 hours, so 23 to go. Let's talk about, so this next kind of, the next piece of this, and I am taking notes just so you all know. The next kind of piece of this is like, what strategies can the MAC use to engage more midwives? 10 attendees is not enough. That is not the MAC meetings of old, right? I'm wondering if there is a way that we as the MAC can engage midwives without burdening them even more, and improve that kind of responsiveness between the MAC and the workforce and the consumers that choose midwifery care. Does anyone have any suggestions or ideas for that? because it seems like we could kind of do that with a little bit less with less interaction from the actual medical board and waiting for them to approve. Like if there's some sort of communication that could go out just to midwife licensees, for example, or you know, thoughts? We can just move.
Yeah, I think that's great that you mentioned that, because something I was completely unaware of these meetings or even the existence of the MAC after working in California as a very busy and involved midwife for many years. So I'm not sure what the process is for the MAC or how the system is to advertise the meetings, and we can do that as individual stakeholders or as the MAC as well.
Yeah, I know that on the medical board website, there's the itty bitty little banner that disappeared today, actually. All of the meetings are recorded and uploaded to YouTube. And so that's been really helpful for midwives who are at a birth or in clinic and can't make it to the meetings, you know. But those are like things that I'm individually sharing with people when perhaps we could get some other instruction on how people can subscribe to those videos or something like that, you know. This, to be clear, is also something I would expect of our professional organization, you know, and that's a role that they could fill. But if there's something we can do within the confines of the MAC itself, that'd be something that we could do, right? Because I do hear from a lot of licensed midwives that they just don't even know what it is. And MAC members, honestly. So I think finding some way to increase the engagement with these meetings, because it's the only meeting happening that is statewide, that's supposed to involve consumers and licensees. So, all right. Are we ready to ask these questions and see if the public has anything to say? All 10 of them. Maybe we could get one public comment. Should we try? Please, Rosanna, still be listening. All right, if we have no more comments from the members, we can move to public comment and see if anyone has anything to say.
Yeah, anyone who'd like to make a public comment, please go ahead and use the hand raising feature or type anything in that Q&A window. We'll get you called upon. First up here, we have Rosanna Davis.
Yes. So thank you, Ms. Weisner, for this very engaging set of questions, and Ms. Webb, too, for a nice, succinct answer about what's possible. It's always hard to track that, like what is the MAC capable of doing or not doing, and do we need permission to do this or that, and how do we get things done? So I took some notes. On the first question was, how can the MAC potentially better meet the needs of midwives? And a couple of ideas that I had that are probably within the purview of the MAC are to make a habit of doing an annual presentation to the medical board on the practice of midwifery. It's been done every few years, and I think it's been quite a while since Claudia Breglia did her presentation, but it was very well received. And there is quite a bit of turnover that is significant on the medical board. And there's absolutely no guarantee whatsoever that they understand necessarily that the scope and practice of midwifery, and yet they are regulating us. So I think that's a good place to start. Also, other topics of presentation that may be of interest to the medical board and will benefit the licensed midwife community and the people we serve are on the community birth partnership under CMQCC now, which is a pilot program to improve transfers under the model of smooth transitions. And then, of course, the work of MACA, I think would be valuable information to take to the medical board. I think that the MAC could potentially better educate enforcement about the midwifery model of care. I know that you've had some interest in that previously, Ms. Weisner, and that's not something that CALM can do, actually. They don't respond to our asks for a meeting to discuss. They would prefer that coming from the MAC. And then the one more piece was to research and potentially recommend a statute change to include the community birth data registry. I don't know yet if that's possible, but we're looking at it, and maybe the MAC can be the ones to champion such a thing. About addressing sustainability of midwifery practice. Maybe it would be helpful for the MAC to bring someone in to do presentation on stress mitigation for health professionals. Like how to recognize burnout, how to deal with it, how to prevent it, besides getting better payment. There's other personal things that folks can do. On getting midwives to meetings, CALM will recommit to, making announcements that the meetings are happening and that it's valuable to be engaged in that. Yeah, and gee, I used to be on a newsletter distribution from the medical board, and I don't seem to get those anymore, so I'll go take a look. But maybe an annual article from the chair would be nice about what's up in midwifery that physicians could see, and the public. And yeah, and then my question is it possible for the MAC to put out its own newsletter? So anyway, thank you, Madeline, again for your strategic thinking here. I appreciate it.
Thank you very much for your public comment. I do not see any additional requests in queue.
Okay, so as a reminder, that's the beginning of a conversation. Okay. We'll bring it back. Moving on to agenda item number 12. This is a presentation on the Licensed Midwife Annual Report and opportunities for better data collection. And this presentation was arranged for so long ago that that I had forgotten.
Ms. Weisner, I'm sorry to interrupt you. It looks like you're on agenda item number 11. Are you? I just wanted to.
I thought we were. Oh,
are you?
Yeah, right. Can we move it? Can we move it to the next meeting? Can we skip it?
If
I'm just looking at the clock, and I was totally joking about taking 25 hours.
I know. Yeah.
And I also, here's what I realized. I want Ms. Rosalie in on that conversation.
Okay.
So I'm wondering if we can skip it.
So
move it
yes, we can put that on the next agenda.
Awesome. Thank you.
Thank you.
Perfect. All right. Do we need to like move or motion or anything? Thanks.
You've declared it as the chair.
I declared. Awesome. Yay. I do declare. Okay. So moving on, agenda item number 12. This is a presentation on the Licensed Midwife Annual Report and opportunities for better data collection. Just so that you all know, Ms. Davis and I talked about this like a year ago, like so long ago that we both forgot, I think. So much of the presentation is stuff that Rosanna said in her public comment, but I'm gonna go through it again. All right. So that's just the title slide.
Yeah,
We
just let me
can-
know when you like to advance the
Slide,
slides.
please.
I'll
Yeah.
do that for you. Thank
So
you.
first off, I just always share a conflict of interest disclosure. I have no conflicts of interest to disclose on this presentation. It's intended to improve the data collection resources available to licensed midwives. I'm not financially affiliated with anything, but certainly not with any of the tools presented in this guy. Slide, please. So this is a summary of concerns and recommendations regarding the LMAR. It's based on a comprehensive review of the LMAR tool by two researchers from Oregon State University who have the most expertise in data collection for midwifery providers, like in North America. They're the best. And this review was commissioned by Quorum. So thank you, Quorum. Slide, please. So I'm just going to be briefly going through the statutory authority for the LMAR, some concerns about the data collection tool, immediate concerns, and opportunities that we have for improvement here. So the statutory authority, Business and Professions Code, Section 2516, requires licensed midwives to complete an LMAR. Statute includes the report due dates, the information specifically to be collected, the description of how HCI accepts and uses the information, notes on coordination with other data collection systems such as Stats, and everyone knows this, but to remind you, the LMAR submission is required to renew your license as a midwife. So the data collection tool is a wizard style tool that's used to compile practice information. It's question and answer style. The questions are presented in sections. They're not all together. So you kind of don't know where it's going as it's going through them. It automatically calculates the values throughout the tool. And a summary at the very end is provided sorted by year. So midwives can go through previous years, what they submitted as well. Here's the website that has the user guide. It is helpful. I feel like every year I open that next to the LMAR as I'm filling out the LMAR just to make sure all my information's correct. So here's some feedback I've received. I just put up like a little Facebook post asking what do you guys think of the LMAR in the California Midwives Facebook group? Highly recommend, by the way. I hope the data collected is not used for any policy decisions because the data collected is severely lacking. I wish there was a better way to collect meaningful data, especially with the large number of midwives in our state with a very unified background in terms of education overall, as it would be great to see statistics. They sometimes won't let me proceed without info I cannot obtain, so I've had to make guesses on certain cases. The LMAR tool made me double report a fetal demise with another state. I work primarily in very rural counties. When there's a mortality listed on the LMAR annual summary, I know exactly which case it was and what midwife attended. Sometimes I see outcomes that I entered that are clearly missing from the summaries. So this is not positive, and you can read more, but this is not terribly positive feedback, and I'd say it's in line with the feedback that I've been hearing about the LMAR since even before the wizard tool came out. And we can just keep it moving. So some ongoing concerns can be categorized in these 4 categories. The functionality of the tool, it can feel cumbersome and confusing. There's inconsistent language throughout. It's poorly suited to births that are in community settings. There are potentially identifiable events such as preterm birth, low birth weight, VBAC, especially VBAC after multiple cesareans, multiples, deaths, and county-specific data, particularly in rural counties. Information cannot be appropriately be used by midwives or regulatory entities or policymakers. It shouldn't be used by any of those entities. But despite this, it's still used by all of these stakeholders. It's still disseminated by the medical board and by HCI. And you get a very unclear idea of the trends, the actions, and the outcomes. The treatment of mortality and morbidity especially is concerning, and it doesn't contribute to the improvement of safety or the care that licensed midwives provide. So throughout the tool, the researchers found that there are concerns about opaque language. The language is not crystal clear. Denominators are not clearly identified and they're inconsistent. Sometimes the denominators are the parent giving birth, sometimes it's the baby. And these are not the same thing, particularly with multiples or with fetal demise. Some of the language in the tool, you can't even tell what they're asking. There's a failure to capture multifactorial decision making that is really inherent in midwifery care. Perhaps there's a category that's like the midwife's discretion or other category based on the midwife's clinical judgment, but it might not be based on clinical judgment, and it might be a more intuitively derived decision, and the tool doesn't capture that. Midwives express that there are significant fears involving self-incrimination, despite all of us being assured that the information is confidential. There are items that it asks about that are outside of our legal scope of practice, such as twins, breaches, births before 37 or after 42 weeks, where people are going to withhold information because they don't want to self-incriminate, and that's a reasonable thing to do. So the client services section, there's concern about who owns the client for reporting. So there's a risk of double reporting or certain incidents not being captured at all because maybe two midwives switch call back and forth. Maybe a second midwife was called in to finish up the birth or to catch the placenta after a different midwife caught the baby. The way the antepartum intrauterine fetal demise is treated is inconsistent throughout the tool. Doesn't clarify the time of fetal death versus the time of a miscarriage, stillbirth, the time of delivery, or the nature of any of those things. Doesn't capture what happens to medical antepartum transfers unless they're in labor. And you know, there are all of these line items that we can identify that it's just not capturing super well, and any one of these would make this tool not usable for data collection, and we just have a lot of them. And there's many examples that people shared with me of double counting, triple counting, or not counting their clients, or not counting the births. Out of hospital birth outcomes per county, first off, the terminology, it's geared, it identifies things by what they are not, which is not helpful in research. Macrosomia or LGA is not tracked despite being a known risk factor in community births. Our babies are bigger, and our parents are typically like a little bit further along as well. Twins are also, in reality, expected or accepted early and smaller than a singleton baby without carrying the same level of risk that an early or small singleton has. And it's not clear how the LMAR collection tool handles this other than just counting it. The language in the out-of-hospital birth outcomes and VBAC deliveries, as well as some of the client history, is convoluted and unfortunate. Using the word failure as a way to describe a VBAC that isn't completed at home, for example. Onset of labor is not defined. It's left to the person filling out the tool's discretion. So it could be that it's the time of ROM, it could be the time of regular contractions, a certain dilation that not everyone agrees on. Is it 4? Is it 6? Is it they didn't get any exams, so we're just guessing? The denominator of this section is babies, not moms, so it's unclear about how these responses translate to the rest of the tool. The outcomes are not clear. Precipitous labor is included, but prolonged labor is not, despite prolonged labor being an often cited reason for transfer to a hospital or for other intervention in a community setting. So you see what I'm saying here. There's these researchers who just do research. This is all they do, research on community birth. They looked at this tool and they were like, oh dear. So we have this long list of important outcomes missing. These are outcomes that we want to know for quality improvement, but also like to be able to celebrate midwifery care and identify the things that midwifery care is really, really good at. And those are incongruent with the tool, you know. Sentinel event processes. So most midwifery-centered research tools, such as MANA or the Community Birth Data Registry, include a mechanism where if there is a death, the midwife can provide a narrative for what happened. This is important for the data collection itself, but also it's extremely important for quality improvement. And the LMAR does not include this, nor does it seem like licensed midwives would even trust that enough to enter in that information. I did want to give a little bit of a plug for Calm's QI program. It's free for their members. For licensed midwives in California, if they have a Sentinel event and they want someone to peer review that with them and give them like meaningful feedback without a fear of incrimination, you have that option through Calm. And it's a very like restorative, reflective process that doesn't assign blame or get you in trouble. The goal of it is really to improve your midwifery practice. So despite our data collection tool not having this, Calm has this. So the summary of this report from these two researchers is that the LMAR tool is inadequate in such a way that it cannot likely be repaired to a point that the data is usable. Simply put, it is not worth fixing. And our ongoing maternity care crisis is more expensive to stakeholders than the replacement of this tool. The cost that it would take to go through and fix every little thing and fix the manner in which the information is collected and aggregated and disseminated, that money would be better spent just like actually keeping people safe and well. Midwifery stakeholders, including medical board members, licensed midwives, clients, and policymakers should know that the data collected by the LMAR is not usable for research or quality improvement. That's the official opinion of these researchers. And medical board staff allowed me to put that in the presentation. Thank you. So reasonable goals for a data collection tool for the LMAR should be that it fulfills the statute, because the statute says exactly what it has to have in it, but it doesn't limit it to the things listed in the statute, right? You can have more. It should be functional, verifiable data collection that is user-friendly so that people actually do it and do it correctly. Should improve patient safety, improve the quality of care midwives provide, And ideally, it would lessen the administrative burden on providers, on patients, and on regulators. So some opportunities for data collection where these things have all already been done or can be slightly tweaked to meet the needs of the statute. As Ms. Davis pointed out, the Community Birth Data Registry is a specific data collection tool. It is cost effective. It uses, it is made for a community birth setting. So it's not trying to fit like the square peg of licensed midwifery care into the round hole of hospital-based care. It is fit for purpose. And there's some information about that there. There's also Manastats Plus. Many of you are probably familiar with Manastats. Manastats did a redo and is Manastats Plus now. I'm not super clear on it. But it came in kind of like the spread of things that might be considered if we're looking at community birth specific verified collection tools. And then there are a couple more. Individual electronic health records programs do collect information. I have used all of these programs and they all have great things about them and also things that where I'm like, I want to throw that in the garbage. So, but they're not like verified by researchers in the same way that those collection tools are. One thing that is not included in this presentation that several people brought up to me is PDR, the Perinatal Data Registry. This is a similar data registry to the Community Birth Data Registry. It is used mostly by birth centers, but it is also fit for purpose for a community birth environment. And it is included with membership to the American Association of Birth Centers. So all of these have costs and all of these have advantages and disadvantages, but I wanted to include all of them to mostly let everyone know that there are other options out there that are, and they're probably all better than the LMAR tool at this point. Oh, BirthTrax tool. BirthTrax is also, it's not an EHR. It can be used as practice management, but it is used to track your births. It's used to collect certain data points, and you can actually like make your own data points too if you want to collect information on like how many redheads you work with or something else like that. You can create your own. So as far as discussion goes on this, you know, this might be an opportunity for the MAC to pitch to the medical board like, hey, we found not only is this tool maybe not working for us, but we have another tool that we would like to replace it with, if that's possible, perhaps with a statutory change, as Ms. Webb was talking about. And so these are some questions that we might think about or ask amongst ourselves. It sounds like a legislative change would be necessary to at least add like the option of if a midwife is submitting to this data registry, this meets the requirement for submission to the LMAR, something like that. I know that this is something that Quorum has been floating and working around as well, but I think we can probably join forces on it and figure out something better than what's happening now, which is we're spending all this time putting in our data so that we can renew our licenses and the numbers are useless. They're just not capturing what's actually happening in the state, which I would think would be the goal of the LMAR. Anyway, this concludes this presentation. I would love to hear what other MAC members have to say or if they have questions about this. I would also like to just express my gratitude to the researchers who spent all this time wading through the LMAR tool and shared a lot of the grievances that every midwife has had about these tools. So thank you. Any comments or questions from the members?
Just agreeing with you, Ms. Weisner, about if this could be a topic we could present to the medical board, and hopefully that could be one of the things as the MAC were able to support with recommending change and the different options presented in today's presentation being part of that. So thank you again for sharing.
Thank you very much for that presentation. It was a long time ago, but I do remember being present at the meetings where the LMAR was first established and was first being hashed out. And I do remember that the California Medical Association used statistics from the LMAR to suggest that the entire LM designation be eliminated in California in 2013. That was one of their lobbying points. So this has been used as it has been weaponized. Even if the information individually is anonymized, this reporting tool has actually been weaponized. If it's not of academic use and it doesn't apply to other practitioners, then it is just an oversight tool that has the propensity for weaponization. I don't understand why it is that we're still supporting the LMAR. It either needs to be completely eliminated. If we need actual statistics, it needs to be replaced. If it is statutorily appropriate for providers in California to be reporting their statistics, then that should apply to all licensed providers under the medical board.
What a good point, right? What a good point. If we were to request that physicians report their cesarean rates or their induction rates, or how often they are using scissors to dissect someone's perineum when they're having a baby, or even things more benign like that. Like, how often are these providers meeting the patients before they're in labor or taking care of them after they give birth, it's an interesting double standard. It's absolutely weaponized against us. And also, on the flip side, licensed midwives take this information and think that it is honest and accurate and useful in order to promote licensed midwife practice. And that's concerning as well, because it doesn't capture what's actually happening. I don't want for us to be making our own propaganda about ourselves that will be weaponized against us, So I'm wondering if, obviously we're gonna continue this conversation later, but
I would be very happy to present this to the full medical board in person at a meeting.
Yeah?
Absolutely. I don't live very far away. Yeah, that would absolutely
Hey.
would be happy to do this. I'm much
Okay.
closer than you are.
I'd do it, but
So Carrie, I want to ask if it would be appropriate for someone from the board to present to the MAC some information about the LMR and the costs and so forth of making changes and the changes that were made a few years back. Is that appropriate, or?
Yeah, I mean, this is changing the LMAR is very expensive, but I wasn't going to go there, because what I'm hearing is the direction may be you don't want to change the LMAR, which, since the door has been opened, I want to point out was created by midwives. I don't know if you all were around during this time, but we had a number of interested parties meetings and worked directly with midwives to create the LMAR. and the revised LMAR, gosh, it was after 2013. So I don't know, maybe around 2016, 2017, it was revised to gather more information than previously, perhaps trying to address many of the concerns that you brought up here, but I'm hearing maybe it's not sufficient still.
One thing
but
that comes
that,
up,
go
yeah,
ahead.
one thing that comes up a lot talking with midwives is the concept of like the sunk cost fallacy. And like, oh, we worked so hard on this. And every midwife I know has this conversation about just being a midwife. Like, I've worked so hard on this
Right.
that I cannot scrap it. And every good midwife I know also knows when to fold. And this tool is not fit for purpose, despite all of the work that has gone into it, and the interested parties meetings, and the yelling, and the arguing, and the what if we count it this way? When it comes down to it, if we're utilizing the information to keep consumers safe, it's not real information. Like, the numbers on that sheet don't mean anything because they're not valid. They're not valid. And
Right. I
so
mean, and you're right. It doesn't mean that you're stuck with this. It's this conversation, it comes up cyclically.
Yeah.
And but you know, there's going to be tension around it because of the cost, and you know, it's just part of the discussion.
Yeah. And it might be that there is such a possibility that the original LMAR tool could be like, could stay, and then midwives could opt into using another data collection tool, providing proof to the medical board that they submitted their data somewhere that that cares about the data. And then they use that for their license renewal. Like, it seems like that could be a potential legislative fix that would at least allow some midwives to contribute to a valid data set. And that's, I mean, that's something that is done in other states too, where you just have to prove that you gave your data somewhere. Someone's keeping an eye on you. Someone's keeping an eye on the care that you're providing. You know, if your regulatory body can't keep track of it, then you prove that you submitted it to a source. And I would argue that it when we contribute to these larger data sets, it keeps the information safer. It keeps the consumers safer as well. I know I can look at the LMAR from certain years and I can be like, that one birth in that county, I remember that so clearly. Or that one VBAC after 4 cesareans that year, like, I remember that so clearly. And that's not safe. That doesn't improve safety. It doesn't improve like the quality of the data for anyone who contributes to look at it and be like, oh yeah, that was me. Those were my triplets, you know? So I'm hoping we can move, like, I didn't do triplets. Please don't come for me. But I hope that we can move to a place where we have a better data collection tool, where people maybe like process their hurt feelings about the old one not being usable. And we can center like the researchers in this, because midwives and researchers, the Venn diagram it's 2 people, and they made this report, you know? I do think that this is worth more conversation than we're going to have today about it. So one of the things on my to-do list was to establish a task force. Could Ms. Wilson-Tenev, you expressed interest in being on my task force? that would allow us to work on this like offline and, you know, come with a more solid proposal for the MAC to present to the medical boards. That sounds okay? Cool.
Yes, I would absolutely be happy to work with you on that project.
Okay. Cool, thank you. All right. Anyone else from the MAC have questions? As far as I know, the final like deliverable of this research brief is something that was commissioned by COM, and COM has ownership of. So reach out to COM if you want the full deets. Shall we ask for public comment on this?
Anyone like to make a public comment on this agenda item, please do so by raising your hand or just typing anything in that Q&A window. Get you called upon. First up here, we have Rosanna Davis. Rosanna, you should be receiving that prompt.
Yes, so thank you for the discussion on a topic near and dear to my heart. I wanted to remind everyone that the original intent, as I understood it, of the LMAR was to regulate midwives, understand the physician supervision of licensed midwives and the reasons for transfers. And it has, I don't know, grown and morphed into something else. And I don't think that we should focus on anybody's hurt feelings if we change it or move it or whatever. But I do believe that fixing the LMAR might be more costly and more chaotic than we would want. But so I'm recommending, I would hope we would see doing more research on possibly adopting a different data collection tool, and then taking a proposal to the medical board to champion such a thing. I would hope that we don't belabor to the medical board all the problems with the LMAR before we have a proposed solution. I don't think that would be helpful. And then the other thing on data collection is that I would hope we would see eventually, and it's going to take a statute change, better collection from vital records in the form of implementing data fields that collect information such as planned place of birth, planned care provider, and some information about what happens to mothers and babies when they transfer. So something else to consider, but thank you for the discussion.
Okay, thank you for your public comment. At this time, I don't see any additional requests.
Cool, thanks everybody. We're almost there. Let's move to agenda item number 13, future agenda items. Do any members have agenda items for the next MAC meeting?
I do. As you may all know, I'm a licensed midwife and also a doctoral researcher. I specialize in maternal health, birth culture, and the socio-political dimensions of reproductive care in California. In 2022, I produced original research on the rationale for families choosing to engage in free birth, which is the giving birth in the absence of a professionalized attendant. Free births are on the rise, and I would propose a brief presentation at the next MAC meeting on the frequency and rationale for free birth, not to justify violations of licensure statutes, but to offer context for what is often framed as non-compliance. If the medical board is going to issue citations and fines, I believe they have a responsibility to know why families are making these choices. And I would love to share some of the knowledge that I've compiled very briefly.
Awesome, cool. do any other members have agenda items for the next MAC meeting? Before I share my list? Okay. I just have a couple. So my first idea, I'd like a presentation on environmental exposures for a future MAC meeting, for the benefit of midwives, families, their babies. I have spoken with Dr. Kemet Taiwo, who is a leader in the very specific intersection of midwifery care and environmental exposures. She has connected me with someone who specifically has done research on midwifery care and wildfire smoke. And I think this presentation would benefit everybody, all of us. And it just kind of would switch it up a little bit. And it certainly would contribute to the protection of consumers, as wildfires are like an all the time thing now, it seems. So that's one. I'd also like to propose that we have an agenda item that is someone from MACA, one of the members of leadership with MACA, to present on the midwifery payment model and its potential uses for licensed midwife practices. I think that would address a pretty pressing, like, material concern that midwives have. And then my third idea would be to move agenda item number 11 from today to the next meeting. So that would be a discussion on a presentation to the medical board. Does anyone else have agenda item ideas? All right.
Ms. Weisner, can I go over these items with you just to confirm?
Perfect.
So the
Yeah.
standing agenda items, the approval of minutes, the report from the MAC chair, the update on midwifery related legislation, and the program update with the LMAR report that will be at the September meeting. I would also add the vote on the 2026 MAC meeting dates, and also keep in the report from the task force on Medi-Cal related issues.
Okay.
And did you want agenda item number 10 also added the discussion on accessibility and sustainability of California midwives, or we're just keeping number 11, not number 10, correct?
Let's keep number 11, not number 10.
Got it, thank you. And then we've also added frequency and rationale of free birth, Mason Wilson Tenev. The presentation on environmental exposures, who are you proposing to do that presentation?
It would either be Dr. Kemet Taiwo or one of her associates.
Okay. And then a midwifery payment model, and you would have MACA presenting that, correct?
Correct.
Okay. Okay, I think I have everything.
Thank you. Thank you.
Mm-hmm.
So
You're
shall
welcome.
we, like, do we want to make a motion to public comments? Public comments on future agenda items? Is it time for that?
Anyone would like to make a public comment for a future agenda item? Please go ahead and raise your hand or type something in that Q&A window. First up here, we have Rosanna Davis. Rosanna, you should be receiving that prompt.
Yes, Rosanna Davis. That's a very full agenda, but I don't want it to go by for too long. It'd be great to hear from Holly Smith about the Community Bird Partnership Initiative. That's all I have.
All right, thank you so much. At this time, I don't see any additional requests.
Awesome. Okay. Thank you. Shall we hold a vote on this or a motion?
No vote is required. Are
Perfect.
we adding anything or just what we had initially said? What I initially read to you is the list?
My idea would be to talk about having Holly Smith from the Community Birth Partnership on something that we would bring to the full medical board. That would be my idea. But I think we would chat about that next meeting.
Discussion among the MAC
Great.
regarding
Perfect.
Community Birth Partnership Initiative.
Yes.
I would also like to mention, if you would like to take a vote on any of these items, we need to list them as possible action.
Okay.
So if there's anything you want to take a vote on, it needs to be listed as possible action on the agenda. And I will send that to you prior to
Perfect.
posting.
Okay. Okay, great. I'm just looking at the long list of, this is great. Okay. So for future agenda items, we would want to vote on it being a possible action. We're voting for it to be a vote?
No. No, these
No?
are just,
Okay.
these are ideas.
Okay, perfect.
And some of them, not every idea makes it onto
Sure.
an agenda. We do have to, check for appropriate speakers and if it's in line with, the goal of the MAC.
Right.
And we're going to need some additional information to see
Perfect.
if it's appropriate and I'll just tell you, generally when we bring speakers, we're looking for someone from other state agencies,
Cool.
maybe from universities, and not from associations. So
Right.
trying to, really keep it from official sources. So we're just, as staff, we're going to have to gather some information about these potential ideas, but no vote is required. We'll work with you to see what can be included.
Awesome. Sounds good. Thank you. Thanks for taking the time to explain that. Okay, great. Wonderful. Shall we adjourn the meeting? Is it time?
You may adjourn the meeting as
anything?
chair.
I'm gonna do it. I'm gonna do it. This meeting's adjourned. Thank you everyone for your time. I really appreciate it. I hope you all have just a lovely week and thanks everybody.
Thank you.
Thank you.